All right, let's go ahead and get started. Thank you for joining us today. As you know, this is our quarterly provider facing continuous quality improvement learning series. So we're happy to have you here. Just a little bit of housekeeping. If you could stay on mute until the question and answer portion of the call, that would be appreciated. And I'll introduce myself as well. I'm Heather Lober, VP of State Engagement. It is my pleasure to work with all of our directors who run our Atlas program in the 14 states where we are. So that's who I am, and glad to be here as well and hear the content today. So again, just reminder to stay on mute until we do the Q&A session. I also want to thank everyone for the good work that you do, the life-saving work that you do, and we're real grateful that you partner with us and do the treatment facility survey. As you are aware, that is how we have data on our Atlas treatment locator, is via the information you submit to us. So we're really grateful for that. Also grateful for the patient experience surveys or the leave a review function. If you are reminding consumers at discharge that they can leave a review, or maybe you're not able to weave that into the discharge process, but instead maybe you have a flyer in the lobby with a QR code that encourages the patient or consumer voice to be heard by leaving the reviews. We're grateful for that as well. Not only is it a way to get out more messaging about your facility, but it helps other human beings find treatment that's right for them as well. We know that over 70% of people really want to see reviews that others have left before they make their own treatment decision. So we're grateful that you promote that and help that patient voice get out there. Also, if you're not aware, we did start a sweepstakes Monday this week. So once a week, we will do a drawing and give away $50 gift cards, random drawing for people who do reviews. So that just kicked off this week. Wanted to make sure you knew about that. And with that, I see people are still entering, but we'll go ahead and get started. Again, we'll have a Q&A section when you can come off mute. You also could feel free to put questions in the chat and we will monitor that as well. So with that, I'm going to turn it over to my colleague, Rachel Cooper from our Stigma team, and let her say some more about herself, her background, and then she will lead into the training. Thank you. Over to you, Rachel.
Thank you so much, Heather, for that introduction. Thanks, everybody, for being here today. A quick heads up, housekeeping on my part, is that I am in a very small town outside of Montreal, and at moments the reception has been a little wonky, so I'm actually going to be off video while sharing slides just to facilitate the process, and hopefully it's smooth. But if I do happen to drop off, I will be right back. So I'm going to just do that now. All right, so here we go. And I'm hoping you guys are all seeing the presenter view now. Hopefully this works for everybody. But again, thank you. And we're here today to really talk about one of the other main pillars of Shatterproof's work, which is the work on ending addiction stigma. So what we're going to do today is to kind of talk a little bit. Obviously, you guys know who Shatterproof is, but we're going to talk a little bit about how we got into the stigma space specifically. And we're going to talk a bit about measuring stigma, some of the healthcare interventions that might be of interest to you guys, and then talk a little bit about some of the action items that we can all take together, right, as individuals, and then also for healthcare professionals as well. I will do Q&A at the end, which makes it a little bit easier just to get through the flow, but then I'm really excited to hear your thoughts. And especially from the view of addiction treatment providers specifically, as opposed to broad healthcare professionals, my guess is there's going to be some really good conversation at the end. So thanks again for being here. So I suppose I didn't really introduce myself. My name is Rachel. I'm the Senior Director of the National Stigma Initiative here at Shatterproof, typically based out of Madison, Wisconsin. So for those of you who are here from Wisconsin, hi, hello. But right now, again, outside of Montreal, I've been with Shatterproof for about 2.5 years. As you guys know, we're a national nonprofit dedicated to reversing the addiction crisis, in the United States. My personal background is very much in the harm reduction space. So harm reduction, and then working in the kind of the policy space around employment and substance use. So the stigma work is something that is near and dear to my heart and has shown up in multiple ways throughout my work. So as you guys all know, right, Shatterproof has multiple different branches to it, right? We work on the side that y'all are on, so revolutionizing the treatment system with the Atlas program and all of the varying affiliated work that's there. Supporting and empowering communities is obviously a critical component of this as well. And then what we're going to talk about today, which is breaking down addiction stigma. So how did we get to this? How do we know how do we know that it works is a question that we think about a lot in the stigma world, right? Trying to develop metrics that actually look at measuring change, all of these different things. There's a lot that went into this. And several years ago, we said, okay, we know that addiction stigma is something that people talk about all the time. We talk about stigma every day, right? How it's a barrier to treatment, a barrier to recovery, a barrier to education, all of these different places. It plays a role, barrier to harm reduction services, etc. So what we did is we looked at 100 plus publications and reports, peer-reviewed articles, etc. We assessed the analogous social change movements to understand how they shifted their beliefs and behaviors. So things like the stigma surrounding HIV/AIDS, mental health and mental health disorders, gay marriage, etc. And we conducted interviews that looked at social change and addiction, etc. So again, really looking at how do we inform our work, and then ultimately, behavioral health more broadly. That led us to really identifying the drivers of the overdose crisis itself, but then how 7 of those 9 particular drivers are driven in themselves in part by stigma. So what we're looking at here, we're seeing, of course, the first 2 about the marketing of prescription opioids, something that we're all familiar with. Access to heroin and fentanyl as well, and varying fentanyl analogs is stuff that's less stigma driven. But the other ones, looking at things like shame and social isolation, looking at people not seeking help for their substance use disorder or addiction, even when they do, looking at insufficient treatment capacity or non-evidence-based treatment, or things not being covered, right? Obviously, criminalization is a big component of this, but really at the end of the day, stigma is it drives social and structural barriers to recovery. So this is where we started. We said, okay, so we know that it's driving certain parts of this, right? What do we do? And to do that, the first thing that's really important is really to identify and define, what addiction stigma is. And part of the reason why this part of the conversation is so important is because everybody thinks of different things when they think about stigma. We all have our own perceptions, our own beliefs about what stigma is. So how we define it here at Shatterproof is we think about stigma as a mark of disgrace that's associated with a particular circumstance or quality or person. It's a barrier to receiving healthcare. It's a barrier to engaging in help-seeking behaviors at all, and ultimately results in discrimination and exclusion. One of the things that I want to point out on this slide is that what this doesn't say here is that people are doing the stigmatizing, right? So this first sentence here is kind of a passive voice. A mark of disgrace is associated with. But there are people and systems that actively do the stigmatizing, or sometimes passively do, right? We all have our things that are ingrained in our head. But it's important that we realize that this is an act that people actually take. So the 3 types of stigma that we talk about here at Shatterproof really focus on public stigma as the first. And public stigma is what most of us envision when we think about stigma. We're thinking about society's negative attitudes towards groups of people, these attitudes that create environments where people feel unwelcome, judged, shamed, blamed for their whatever the characteristic is, right? In this case, obviously with substance use disorder. This particular area also really does include stigma towards medications for opioid use disorder. So the idea that people who are using MOUD aren't quote unquote clean or in recovery, etc. Those attitudes very frequently are found in public stigma, the public stigma world. We also talk about structural stigma, which is more that systems level discrimination that's caused and codified by some of those institutional policies or dominant social norms. And the point that I'd like to make here is that, I mean, really, it is still us as individuals who create structures and systems, right? So we vote people into office, we participate, we have both big P policies and like little P policies, so think like workplace policies. Our beliefs and our biases, all of this is stuff that shows up because we participate in society. So these different things, right, that we look at as far as like the structure. So think about, differing access to methadone, the removal of the X waiver. When we're looking at the treatment world, there are certain things that are caused by the systems, right, that have been built into systems over the past decades by people and their beliefs. The third part is really self-stigma, when that's where people really, kind of internalize the societal stereotypes and experience that reduced self-esteem and self-efficacy resultant of what people believe about them or what people believe then about themselves. So I wanted to talk a little bit about, where stigma begins, right? Because stigma really, at the end of the day, starts with stereotyping. And stereotyping is something that we learn when we're little, like think like 3-4 years old, right? We start to learn things about the world, about people. It's relatively unavoidable, right, to learn stereotypes. So the work when you're an adult comes in with consciously unlearning those stereotypes, right? It's a conscious unlearning versus an unconscious learning. But stereotypes lead to prejudice. They lead to these beliefs about people that are, often inaccurate or damaging. So in terms of substance use, you're thinking about the people with a substance use disorder are dangerous or dirty or, unworthy, like those things that people, like they both start to believe at a certain point. And then those prejudices lead to to discrimination. So disparate access to employment, healthcare, treatment, housing, etc. In the case of substance use, in particular, one of the things that we know is that beliefs about competence or dangerousness drive specifically a desire for social distance, and then accordingly those discriminatory attitudes and behaviors. So an example of this is that believing that people with a substance use disorder aren't competent to make their own healthcare decisions or to hold a job drives a desire for social distance, an example of which would be, I don't want that person as my neighbor. I don't want them in my workplace. I don't want them to marry into my family. So that's what we mean when we say social distance. And the resultant discriminatory behaviors then would be, I'm not going to hire somebody to work for me. I'm not going to support, a group home in the neighborhood, etc. So at the end of the day, just to drive the point home, stigma is deeply, deeply entrenched here, right? So this discrimination and the isolation comes in at points when people are very vulnerable and feeling very low. So the exclusionary stuff that we think about when we think about where do people sit in the world, when it hits when people are feeling very low in that space, it really to me speaks to the need to recognize how this both is fueled by deeply entrenched like beliefs that started when we were really young, but also the need to really think about this as adults and really focus on how our attitudes inform our behaviors and then vice versa. As far as some of the components of stigma, there's a few ways to look at this. So I'm just going to go through a couple of them just so we can kind of build a cohesive vision of what this is. So one of the main components of stigma comes through as labeling, right? And labeling, like we know that language hurts. Like people say, what is that childhood saying? Like sticks and stones may break my bones, but words can never hurt me. And politely, like that's kind of trash. Words hurt people. And that's okay. We need to be cognizant of the fact that words hurt, but they can also help, right? So it does go both ways. As far as the labeling goes, though, that's a big part of stigma, right? That really drives what we believe. Stereotyping, I mentioned, distancing, I mentioned, discrimination, I mentioned, but I specifically wanted to mention the status loss part. And when I say status loss, what I'm talking about is the belief or the desire for, like I said, don't marry into my family. I don't want you as a supervisor at work. I don't want the resultant status loss of having a substance use disorder for many people really drives this thing where like, I don't want this person to advance in society or they're not worth advancing, right? So that's one of the things that can really also get internalized in the self-stigma world, which I wanted to talk about here when we're talking about, internalized prejudice, which is where you start to not only believe these things about yourself, but then perceived discrimination, which is where if I say something, then I will be discriminated against. If I go to a job interview and mention that I, am in treatment, I will be discriminated against. If I tell my manager that I need to go to meetings once a week in the afternoon, I won't get promoted. If I disclose to my girlfriend that I have a history of substance use, then her family won't accept me. Those perceived discriminations are really important when we conceptualize barriers to sharing, especially in this space where oftentimes we really value people sharing their stories. We really value people's lived experience, but it can come at a cost, right? So the perceived discrimination is certainly something that says, okay, so maybe even if we do the work to address public stigma, we work on changing policies, how does that trickle down to really address the internalized prejudice and the perceived discrimination that people experience? Lastly, I just wanted to mention some of the very specific components of the social stigma, because social stigma is a really big part of what we work on. A lot of people hold high levels of blame. So, like, it's somebody's fault that they have a substance use disorder, or fatalism, which is that it can't be cured, right? It can't be treated. And then, as such, why bother caring? Social distancing, we've mentioned. And then the dangerous one also really does drive a lot of this, because people don't want dangerous items, people, circumstances around themselves, their loved ones, their homes. So as long as there's the perception of people with a substance use disorder as dangerous, it's certainly something that is a barrier to really reducing stigma, both societally and individually. So all of this information said, this kind of academic look at what stigma is, what it isn't, how it manifests. One of the big questions that we've had at Shatterproof and across the field more broadly is, how do you actually measure reductions in addiction stigma or changes in addiction stigma? And the reason why this is such a big question is, well, it's one thing to measure knowledge change. Okay, so you took a training and now you can list off the differences between different types of treatment modalities, different substances, different harm reduction services. Cool. What about the actual attitudes and behaviors? What has changed, if anything? So to answer this question, we worked with researchers at the Ursi Institute at Indiana University to look at, to develop a measurement tool that assesses attitudes about substance use in people who use substances from the public. Also takes a look at people who have or have had a substance use disorder to look at the self-stigma part, and then really can inform some of the structural work that we can all do as far as advocacy and understanding what people support. So the reason why I'm going to go through this, a couple of reasons. One is that it's important to kind of benchmark where we're at, right? To understand what the levels of stigma are out there. But secondarily, we did oversample for healthcare professionals. So there's extra data about some of the stigmas that healthcare professionals hold as compared to the general public, which I would love to share with you as well. So what we did briefly, and if any of y'all are data people and want more details, I'm happy to send like the report, or if you think that would be something that you want to utilize in some way, this can be used in a whole bunch of different ways, happy to support as well. But what we did is we used 3 different indexes or indices that measured public, structural, and self-stigma. And the way that this works is, it's a group of items, individual data points that scale well together to kind of get a broader snapshot as opposed to looking at very specific measures. It means that we are able to set baselines, really look at comprehensive progress measurements. And the other part that made this unique is that we utilized a vignette strategy. So we were able to look at how stigma varies by substance type and by recovery status. So we were able to look at alcohol, prescription opioid, amphetamine, looking at the differences between how people stigmatize on certain substances, and then also again looking at inactive use or recovery. So people read a story, a little vignette called about a person named John, and you can see the intro to it here right on the slide. We were just asking about thoughts and feelings, right? The actual vignette itself describes a substance use disorder using language that mirrors or mimics actual diagnostic criteria from the DSM-5 definition of a substance use disorder. So what it doesn't do is it doesn't say substance use disorder, it doesn't say addiction. And the reasons why we really wanted to focus on that is that we wanted to really keep this neutral tone, right? The minute somebody hears the word addiction, people start thinking about certain things, right? Using the actual diagnostic criteria from the DSM-5 means that we're able to mimic a real substance use disorder profile. So people are actually reacting to the actions as opposed to the label. It also means that we know what people are reacting to. If you say the word addiction, everybody visualizes something different, right? So by listing out the different behaviors, we are able to really standardize the type of person that's being visioned when people are responding to the survey. So at the end of the day, it means that it really does replicate how a typical person would interact with somebody with a substance use disorder. Things we liked looking at, we looked at diagnostic labeling. What we saw, and I'll go into some of this in a bit more detail in a moment, relatively weak belief in substance use disorder as a chronic medical condition, moderate levels of belief still in substance use disorder as a result of moral failing, moderate desire for social distance. Again, that's the social distance stuff. There is the stuff that looks at, do you want somebody as a neighbor in your workplace, in your family, etc. And then we looked at some traditional prejudice measures, and what we're seeing is that a lot of the traditional prejudice stuff carries through into long-term recovery, which I'll discuss in a moment. So again, some general results of interest fairly quickly here. Less than 1/4 of respondents view substance use disorder as a chronic disease. Now, that is a mixed statement, right? So there's been a major push over the past 10, 15, 20 years to redefine substance use disorder as a chronic relapsing brain disease. Think the NIDA definition, the CDC definition, SAMHSA, et cetera. There are obviously other views of substance use disorder, including a substance use disorder kind of as a biopsychosocial model, which we did not measure, right? So again, but from the layperson perspective, from people who don't think about substance use very closely, who don't live and breathe it every day, we're still seeing that less than 1/4 of people view it as a substance, as a chronic disease. Which is kind of, these are not mutually exclusive, right? But we are also seeing that over half of respondents still hold beliefs that substance use disorder is caused by a bad character or lack of moral strength. So, when you take those two data points, again, they're not mutually exclusionary, but it does highlight a couple different things, right? But, from the stigma reduction standpoint, when you think about the causal statement of substance use disorder being caused by somebody's bad character or lack of moral strength, that can go so many different ways. First of all, simply put, it just presents a barrier to all sorts of things, but it also think about how that trickles down into that kind of internalized prejudice, right? People believe that I have bad character or that I'm not morally strong. How does that impact people with a substance use disorder, right? And their actual desire to access treatment. From the distancing point, we are looking at roughly half the public not being willing to move next door to or be close personal friends to somebody with a substance use disorder. And the point that I think about here mostly with this particular data point is that we probably all do live close to and are close friends with somebody with a substance use disorder, right? Or even if we're not, then like one of their loved ones is. And sometimes I think from the stigma perspective about the doors that sometimes individually we may have closed, right, by some kind of like offhanded comment, or, let's see, if there's something, maybe again, think about like the neighborhood association, right? Like who's advocating for what in that space. But if you have a close personal friend who has a substance use disorder and hasn't disclosed, and this is going to manifest differently for a lot of y'all because you work in the addiction treatment space. So people, know what you do, typically speaking. But when I'm thinking about the general public, sometimes the best help that you can give somebody is just to help them navigate the system a little bit. It's to find the right phone number or to help like look at what some of the local resources are. But people aren't going to come to people if they don't think they're going to be welcome, right? So this to me, it speaks to, a work to be done very specifically in the social distancing space. The second to last bit that I wanted to highlight here is that stigma does persist even when a person is in long-term recovery. So because we had half of our vignettes with somebody in, actively using and half in recovery, we were able to compare and contrast levels of stigma. But the comparing and the contrasting part wasn't what actually captured our attention for this particular bit. What we're looking at here is that even when somebody is in long-term recovery, we're looking at, more than half of respondents saying, I still don't want that person as my supervisor at work, and I still don't want them to marry into my family. So, this is definitely one of those data points that, while complex, right? Like there's a lot of different moving parts here, speaks to me of the long-term nature of the stigma reduction work that needs to be done. And also that it's not as simple, and you guys know this, but sometimes not everybody does think about it this way, that it's not like I'm just going to get treated and then I'm better. this follows, right? And disclosing is hard and it can be dangerous for people's mental well-being. So I think, to me, this really just speaks to the long-term nature of the addiction stigma work, and also the fact that this doesn't just magically go away at any given point. From the last thing I wanted to note here simply was that we're looking at over 40% of respondents viewing medications for opioid use disorder as simply substituting one addiction for another. And from the lay perspective, if you've never thought about methadone or buprenorphine, I mean, when you don't know much about it, it can come across that way, sure. But what I'm thinking about here is for people who do have a substance use disorder, when you're seeking treatment, when you have an opioid use disorder, what are these options that are out there, and what have you heard? What do you believe about MOUD? Is certainly something that really impacts, and stigma is a component of that. So for y'all, like, the way that the index would be used probably isn't something that you would think about much in your day to day, but we do use it as a pre and post attitudinal change thing that we center around interventions. We use it to benchmark. Some of you guys are in states where we run the index, including California is a good example of that. And then it does inform priority or policy priorities. So for those of you who are involved more in an advocacy space, in your spare time, if you work on harm reduction work, or increasing access to treatment, or some of those policy parts that go into increasing access to treatment, there's information that can be garnered from the index that really looks at public opinion and can be used in that way. So the other part, and I mentioned this briefly earlier, since we did oversample for healthcare professionals as pertains to substance use disorder stigma, wanted to share a couple things quickly. One is that the healthcare professionals and the chronic disease belief is roughly mirrors the general public. We do see slightly higher levels of healthcare professionals who don't want to move next door to somebody with a substance use disorder, or who would be unwilling to have a person with an SUD as a close friend. And when I think about this, I mean, this has a lot to do in my mind with the day-to-day interactions that people have, and just the way that this manifests out in the world. But is just a note, for all of us, that I think people want to believe that healthcare professionals, because just due to education, right, hold lower levels of stigma, and sometimes that's true, and sometimes it's not. Stigma is just complicated, right? And it's a note for us at Shatterproof, which has really dictated some of our work in the substance use disorder and healthcare space as pertains to stigma, knowing that it's an area of need. With the stigma part, though, some of what we do know is that addiction stigma does actually manifest in clinical practice, and these are some examples, right? That liver transplants are delayed or not received, denial of valve repair surgery for endocarditis cases, reduced access to some of primary care services or pharmaceuticals with the birthing population or pregnant patients. Obviously, there's a lot there that goes into that, especially with neonatal abstinence syndrome, et cetera. But there's a lot of literature and a lot of work that's being done out there, specifically in these spaces, and how it actually manifests, and what can actually be done about it. What we also know is that, I mean, honestly, like, stigmatizing language in a medical record does result in decreased treatment of pain. And medical notes are an odd space, right? People learn from a whole bunch of different ways. I mean, I've looked at my own medical notes from time to time, and it has nothing to do with substance use, but have been, the language in there is sometimes stigmatized to the next person. The other note here is that, like, obviously medical students don't walk in the door intrinsically holding higher levels of stigma against people with a substance use disorder, right? But the interactions between attending physicians, residents, medical students, it's a workplace, and it's a place where we're providing care to a lot of different people. Some places, like you guys, when you're providing specifically addiction treatment services, it's all day, every day. Something it's not for, in other ways, but there are obviously, attitudes do influence beliefs, and you learn from the people around you. So it does speak to the need to, both work on this from an individual perspective as well as a systems perspective. So what we did then, kind of in this healthcare space, is we started off about 2 years ago, really looking at what works to reduce stigma in terms of the actual pedagogy of it, right? So we compared and contrasted, 3 different modules. So one is, a general education module, one of our flagship programs, which is a 30-minute online self-paced mobile program that focuses on reducing stigma and increasing awareness. The other is a longer digital module that's developed specifically for healthcare professionals to help them identify and address stigma. And that's an independently paced thing that you can do, and it's free, which is lovely. And then we compare that, the third thing, to a classic kind of echo learning session. So 4 hour-long sessions. They, in person should be in quotes. It was virtual still, but with the cohort mentality of having an expert panel talking about case studies, bouncing off each other and learning, right? So the data from this particular program is actually being analyzed now. We use the index in addition to other metrics to assess attitudinal change. And to the Atlas folks from Shatterproof on the call, once we have results from this, I'm sure we'll be sharing this over to you to look at, so that you guys are aware of some of the honestly, the results. But really what we want to see here is what works best, right? In cohort versus, self-paced, length, etc., recognizing that everybody is busy and that it's a big topic. So we're excited to see these results. Definitely something that we've been working on and looking forward to for a while. This also really informed another flagship grant that we have from the Elevance Health Foundation, which is a 3-year fully funded project that's looking at reducing healthcare provider stigma through health equity frameworks. So, that really looks at reducing addiction stigma in healthcare systems and among providers, lots of different areas, by looking at essentially healthcare addiction stigma through a health equity framework. And obviously there's a lot of intersecting components here, right? So what we had to do was really figure out, who our priority populations were, but really working to eliminate barriers to addiction treatment and care that are imposed by stigma and discrimination. And then, of course, at the end of the day, equipping healthcare professionals to actually provide, the robust and appropriate support and care. So that formative research phase included analysis of a ton of data indicators that were looking at both state and sub-regional level for analysis, right? So both unintentional overdose fatality rates, non-fatal overdose rates, very socioeconomic indicators, demographic indicators, and then of course looking at the CDC's social vulnerability index led to the identification of actually the Hispanic or Latino communities as a priority secondary population for this project. So lots of work that was done to get to this point, but understanding that provision of care through a quote unquote health equity framework does not look the same for each priority population. So the work that we're doing here again is focusing on the Hispanic and Latino community as that kind of priority secondary population. So it's going to be 7 asynchronous e-learning modules that are in develop right now, leveraging both qualitative information and quantitative information. And then there's a lot of metrics and indicators of success that are used for this project, including knowledge change, attitudinal change, and then assessing changes specifically kind of in referrals to treatment. Again, this is getting to addiction treatment, working with a lot of emergency departments, primary care providers, et cetera, how we're actually getting people to treatment who need to be referred to treatment. So are we seeing a change there is the idea. So super excited about this project, one that we're, just wrapped year 1. So again, everything is in development right now. We have an amazing group of professionals on the team, including an extraordinary advisory board. So we're really excited to get this launched in the field in the coming months. So all that being said, just to talk a moment about some of the key actions, right? So again, we talk about individual actions when we kind of talk about what we can do, more broadly within the idea of stigma reduction as, kind of a training or intervention type thing. We really look at, using person-first and recovery-centered language, right? So what that looks like, I'll talk about in just a moment here, but the idea of using person with a substance use disorder, recovery is probable, recovery is possible, et cetera, are all important, right? As far as making sure that we're not inadvertently increasing biases. Identifying and eliminating structural barriers is obviously a critical component of this. I'll use some examples in just a couple slides here. The sharing stories component. So for those of you who work in the space, of more of the advocacy space, we do talk a lot about sharing stories, like how important it is to share stories of hope and success. But what does it look like to do that in your world? What does it look like to provide protection for the people who are sharing their stories? And then sometimes not only sharing stories of hope and success, but also of the reality of what a treatment journey can look like, right? Sometimes it can feel like, where we only see the end goal, but we don't see the process, that it doesn't necessarily reduce stigma in the way that we necessarily want it to. And then lastly, of course, if you are in a place to do some of that incorporating of stigma awareness and reduction trainings, obviously something that we recommend doing as well. So for the language piece, just briefly, there was a study that was done a few years ago where mental health and substance use treatment professionals were provided a vignette of a patient who either was called an individual with a substance use disorder or a substance abuser. And the people who got that second one with the phrase substance abuser were more likely to say that the patient was personally responsible for their illness and supported punitive action. So we have, within the realm of people providing services to this population, a very strong indicator that literally changing the term substance abuse or substance abuser to substance use disorder, or a person with a substance use disorder, actively changed attitudes and behavior and increased access to care. So, one of the other things just to note here quickly is purely that, people might refer to themselves as an alcoholic or an addict or something like that. And when that's the language that somebody is using to describe themselves, that is their choice, their words, their language. It is not on us to dictate how people should talk about themselves. But, as a professional, using terms like substance misuse, person with substance use disorder, recovery, as opposed to like dirty, clean, etc., is something, of course, that we should all make sure that we're doing to the best of our ability. From that structural barrier point, I mean, there's some very specific things that we can advocate for more in that healthcare space. Addressing some of the misunderstandings of regulatory environment, increasing care coordination or supporting care coordination. What does it look like to make sure that people's treatment is not interrupted? And all of us in our different roles are going to have different actions here. These are just a few examples. I think, from the personal advocacy standpoint, we do all participate in society in certain ways. If you do advocate with your neighborhood council or your neighborhood association for certain things, that's important. You could be looking at your own workplace, right, and saying, well, I don't think that this policy supports employees well enough. Lots of different spaces to advocate, but again, as a person with a voice, if that's how you choose to use it, then that's a good way to address some of those societal and structural stigma concepts and systems. That said, if you are going to be a person who is doing a stigma reduction training, if you're sitting there and thinking you could do an hour-long lunch and learn on this topic, these are kind of the things that we think about here. So these first three are kind of for a shorter type intervention thing, right? So like tailored messaging, right? Or contact-based strategies, person first language. So, let's just say that you're thinking about doing a lunch and learn, well, your audience is healthcare professionals, right? This is where you work, this is who you're working with. So messaging around, might be more appropriate for, like, say, law enforcement, or defining MOUD. It might not be the appropriate messaging for this audience based on their levels of knowledge. But what does it look like to understand what some of people's core beliefs are, understanding what we might want to talk about for that specific audience. Contact-based strategies are always important, humanizing the condition. And y'all see people in person, right? So this is a little bit different probably for the way that you guys do this. But again, remembering that people are people, which and some of those other things. So sometimes we end up in a space where people end up kind of purely defined by their substance use disorder, and people who are also parents or coworkers or who participate in society. What does it look like to do some of that sharing in that way? Person first language education we definitely talked about, but it's certainly a kind of a relatively low hanging fruit. And on the last page of the slides, which Heather obviously feel free to distribute, there are some references and some points up for some of those easy to access language tools. So again, that'll be shared out your way as well. And then for those of you who are thinking, well, actually, maybe we could do something a little bit more robust, the ideas of continuous evaluation, again, that's how we use the index to look at attitudinal change. Sometimes we do things that we think are going to work really well, and then they don't. One of the best examples I have of that is that there were some people who did some work in, I think it was Maryland, looking at reducing stigma around drug courts by providing education. They're like, well, we'll educate about drug courts, it'll reduce stigma, and it'll increase support for drug courts. And what happened instead was they educated about drug courts, it increased stigma about drug courts, but then it also increased support for drug court, right? So there's a lot of moving parts to this, right? So always important to look at what's happening in real time, just to make sure that we're, as we dip into these spaces where we don't necessarily know everything, that we're not experiencing some of the inadvertent effects. And the last bit then is collective impact. And what that really looks at is saying, if we're going to pull together like a coalition of people, so let's just say, you're looking like, let's do some work in the community on this. And I have the healthcare provider lens, and we're going to work with some prevention people and some harm reduction people. Let's see what we can do to reduce stigma. That's a great plan. The idea of collective impact is saying, what is our common goal? What if we set aside our own individual, organizational goals for a second? How can we come to a common agenda, a common goal, so that collectively we can enhance our impact? So for those of you who are thinking bigger picture, that's kind of where this sits. All right then, so I'm gonna stop sharing slides and come on video, hopefully, and we can kind of do some Q&A, talk through what we've got here, and we've got about 15 minutes left, which is right on schedule. So I'm happy to facilitate however. And thank you guys for listening. I know that was a lot of information rather quickly. So feel free to throw in the chat, or can you come off mute as well?
So we did have a question in the chat asking about if they will have access to the slides after.
Yep, absolutely. Also, hi, Jen. Yes, go Madison, Wisconsin, etc.
So do we just ask a question, or do you want to end the
Go
chat?
ahead.
Okay,
No,
so I wanted to thank you very much for this presentation. I think stigma is deeper than we want to even admit, and we struggle it with our community, and it's not, I don't think it's personal. I think it's just not understanding, right? And I never really thought about the professionals actually having as much stigma, right? And we experienced that in a training. So we are going to be doing some work with our agency, which is a county agency, on stigma within our agency. And then hopefully that kind of starts bleeding more out into the public if we can educate those and change the language, right? People who use substances are not dirty.
Right.
And people who are homeless that use substances are not dirty. So we want to start changing the language, and this training was very, very inspiring. I'm definitely looking forward to seeing all the reports coming through with that new survey. That's going to be how to actually do this, and those 3 trainings that you were talking about, and being able to take this back to our team. And I want to thank you. And I think something has to happen, because it's everywhere, and people are dying alone, and that kind of breaks my heart.
Yeah. I appreciate that, Sunday. I think that when we got the initial results, I think we had that same kind of reaction about the professionals, right? Because we know that education in itself is a really important part of reducing stigma, but it's not the only thing that has to happen, right? So education doesn't necessarily, equate to stigma reduction by itself.
Right.
So when I think about, what you're saying about the language, it does, when we think about this from an interaction standpoint, sometimes I'm like, because I used to run a needle exchange program, right? And the idea there is kind of that 2 minutes of your time can change somebody's life, right? It doesn't have to be a huge, because you can think about this stuff and it's so overwhelming. How do I change society? I don't know. It's it's too big. But the idea of what can you do in the 2 to 5 minutes that you have with somebody to, aside from okay, knowing the resources, obviously having the information at your fingertips, but language and body language as well, right, is a really key part of what can be done to kind of reduce that stigma and actually keep people hopefully coming back, right?
Absolutely.
And so yeah, I think I guess this, so the slides Sunday, which I think I've gotten a couple individual messages to me. Yes, the slides will be made available afterwards. I will send them to Heather to send out to the entire group.
Okay.
There's a couple resources in there as well. One of those
Great.
education modules Sunday, it's a reset from the Dell Medical School at UT Austin, is a free self-paced module that people can take. It's 90 minutes, so it's not like the shortest thing in the world, but it is also eligible for CE. So like that's definitely something that is a kind of an incentive. I saw also a question in the chat here about the survey. Yeah, I can include the survey tool as well, Heather, to send out to everybody, and I'm more than happy to support people as well as they work through it, because it's a longer survey. There's a few things that go into it, but that's part of what we're here to do as well, as to support survey implementation.
Yeah, it was a lot of information, so the recording I think will be very helpful also.
Absolutely.
And one more thing, I'm sorry for taking everybody's time, but that person first language, that person is a human being that has many layers of family and friends, and maybe not around but did. That person first language I think is essential and crucial to reducing stigma, at least like in the agency, and then hopefully it bleeds out to the public.
Yeah, and it definitely takes time. I mean, as we know, attitudinal change takes time, behavior change takes time. I mean, I think about like even something is like, it's like a New Year's resolution, right? Like how many of us have like said that we're going to totally do something for this whole year, and then on January 10th, you're like, well, maybe not. So it definitely trickles down. I saw there was a question here about plans to get people who speak of themselves in a negative way to change the way they see themselves. That to me is a really, I think, an individual question. I know, having spent time, all of us have spent different amounts of time in this space, right? Sometimes people are, need that kind of very direct, like kind of intervening moment where it's like, where like kind of black and white, like this word has negative connotations and like this, but then there's also people who very much take a lot of comfort and pride even in the labels that they're associated with themselves. So I think it's probably an individual question, but I think that the more that we work towards generally changing like the broad language landscape, it all has to do with role modeling too, and like leading by example, how we talk about ourselves, how we talk about others. And that I mean, some people would have a real I mean, like I don't like labels very much. Like I'm one of those people, but some people take a lot of comfort in that. So I've had to really, for myself, kind of like step back and be like, I know that academically speaking that this word carries these negative connotations, but it's a tricky thing to try to like one-on-one say. I think that's positive self-talk versus self-deprecating talk. That makes a lot of sense, Darlene. I think that like, so less about the label and more about like the type of speech that you're using to describe yourself is also a really concrete step that can be taken as well. Are there more stigma trainings at Shatterproof? Yeah, we partner with a whole bunch of, the short answer is yes. The long answer is a long answer, but yes, and I'm happy to work with Heather to get you guys the information that would be needed for that. But we are also happy to come do trainings as well, virtually typically, because we're all over the country, but this is something that we can certainly navigate. So thank you for that. Other thoughts, questions? Vance, I saw you're in Philly. I was just in Philadelphia and met some really incredible harm reduction people who do a lot of work on the ground in Philadelphia, like last week. So I had a great time in your city and really understanding some of the on the ground work that's being done there. So, which is exceptional. So kudos to you and the work that y'all are doing over there.
Well, thank you. Thank you.
Yeah, that was great.
We're working hard at it.
Yeah.
But very interesting topic.
I was talking with your people in Philly. I was talking about stigma. It was a purely like social interaction. Like I actually wasn't there for work. I just happened to like run into harm reduction people because that's the way this world works sometimes. And we were talking about, like the difference between Philadelphia and, it being like the city that it is, but then like rural Pennsylvania, right? And so how like sometimes when people are working for like the state or whatever, stigma reduction efforts can look so different just because it's a completely different world, you know, a half hour outside of Philadelphia as far as what this looks like. So it also really, you know, it spoke to a lot of different things, but also Philadelphia just has such a strong grasp with advocacy and harm reduction movement that it was a really cool conversation to be having.
I'm glad, yeah. We're in the city, right? We're a well-kept secret, and we're right on Drexel University's campus, so
Oh,
to speak, in
awesome.
Penn. We have our own treatment facility, small facility for adults, and we've been here for several years. But the
Fantastic.
stigma piece is really something interesting, and thank you again. We'll work on that.
Absolutely. So I'm seeing a couple other comments in the chat. So one about the 12-step support groups and encouraging self-stigma. You know, that's a conversation, I don't know if William, that we have all the time actually, right? Because 12 steps, I mean, for some people that is absolutely the option that works for them. For some people it doesn't. But I'm not in recovery, I'm not a 12-step person, so like I'm not going to speak to it you know, from an individual perspective, but it's something that is specifically because oftentimes that's the option that is the most easy to access, right? It's free, and you don't need insurance coverage, and it can be available online. That, you know, when people don't know where to go, that is a very natural like first step. That is a place where I think to that kind of point, I have a couple, you know, I know people who again take a lot of comfort in the label of like alcoholic or addict, even though, and then you see it, right? And I'm like, I don't love that, but like again, like that's the way that you but I also think that it's a process, it's a progress, like anything is, right? So, but I hear what you're saying, and like some of that can be, you know, it's a complicated space. It's a complicated one, and you know, I think the undoing of some of those, that internalized prejudice about yourself. I mean, it's in no treatment modality is it like is there like a silver bullet to just fix it all? So, but I do think you're right, and I appreciate you calling that into the group, because I think that it is an important conversation, and especially for people who aren't in recovery to like fully understand it. I think that, or who are using 12 steps to do that. I think there's a lot of, again, for some people it works, for some people it really doesn't, and there's like hours of conversation that could be had on that exact topic. But yes, there's certainly that lens that can be taken to it, and again, some people yes, some people no. So if we're looking, I think Doris, your question in here about, you know, kind of that prevention in elementary school, so looking at, you know, educators on reducing stigma or using better language for students. Yeah, so an interesting example there is we actually did some work with Head Start, so even before elementary school, so looking, you know, at that, you know, early Head Start, so like ages up to like 2 or 3, and then 3 to 5 in actual Head Start programming, looking at working with the Head Start staff specifically, and what it looks like to provide care for families or support for families, because oftentimes, you know, the substance use audience, quote unquote, there wouldn't be the kids themselves, but it would be, you know, what's happening on the family level or in the neighborhoods, or what does it look like to help have those conversations as an educator, right? With the families, what are you seeing? And obviously there's things in there about mandatory reporting and whatnot that you can't undo and you have to work within. But we did some really cool work with them, developing some very broad education modules for people who don't typically think about like that is their role, I guess, especially with kids that young, to be talking about substance use. But what does it look like to provide support for families, again, using better language, you know, understanding some of those components of that social distancing stigma, and then understanding what it means to, like, if a student is coming into the classroom and saying something about what's happening at home, you know, how do you approach that conversation? How does it come to you, etc. So there's a lot of components there, but I think, you know, for us, a lot of the key is looking at, for people who don't work in the substance use disorder space like all the time, because all of us do this all the time, right? We're engrossed in it. Like we think about it 24/7. So for those people who aren't, what does it look like to provide small and actionable steps? Again, so changing language is a really good one. Scenario practicing, if you're doing like a, you know, a lunch and learn type thing, like what happens if a kid says something? What happens if a parent says something? You know, what do you do in those spaces is something that we've also thought a lot about, and some of the education we provided to Head Start on that particular topic to make sure that, you know, families are getting the support that they need in the way that is appropriate to provide it when you're not actually providing services, right? So again, a lot of that has to do, honestly, with community engagement, with what's work, what's on the ground, what's around you, as far as, you know, it's great to like, I mean, that's why Atlas is such a fantastic program in large part, is because it's local, right? It's not like here, call Samsa's line and like get who knows what's actually local to your system, right? What's actually local and on the ground, because sometimes those broad-based resources aren't good enough. They're not specific enough.
So I have a question, I guess maybe more of a kind of a statement
Sure.
/ kind of question is, like when we talk about stigma, we do this a lot in my area. So I'm from Pittsburgh, the director of Pittsburgh Recovery Center, and it's important, I think, for us as providers to work together as opposed to competition, right? And I think that's where a lot of these things come from. At least in my experience, been in the field for 15 years, is, you know, locally in the past, everybody was always in competition with each other, as opposed to assisting the programs that are next door to us, you know, and truly taking like a client-centered approach where, for example, we are a abstinence-based kind of 12-step foundation facility. So I actually took a call while we were doing this. I had to take a call, and the guy's on Suboxone, and we don't do that here. I don't say we don't do that here. I have all the resources necessary of referrals that we partner with all the time to make sure that he gets the right care. So he's driving his own care as opposed to us driving their care. Right. You know, if they're here, there's certain things they do, and if they're there, there's certain things that they do. And just, you know, trying to make sure that when we get a patient or a client, whatever you want to call them, figure out what their needs are and what they're looking for, and find them the right place, even if it's not your place. And I think that really starts internally for us with like getting rid of the stigma within our own organizations and in the organizations that might be around us.
Yeah, I mean, honestly, and thanks for sharing that, Brian. I think that's a great example of that kind of that collective impact model that we were talking about a little bit earlier. What does it look like to set aside like the individual ethos or goals of a program? Like, I mean, and then, you know, if you're working in primary prevention, like the idea is that you don't need people to get to the point where they need harm reduction or treatment services. That's not always going to be the case, right? So what does it look like to build those kind of common goals, to build that sense of community, that network, and to provide, and I mean, it does take, you know, it takes everybody to buy into that type of model. And I think that's where it's hard, right? Especially when it feels like, you know, reinventing the wheel, people have limited time, which is why services again like Atlas are so great, and as well as some of the other like the local coalitions. I mean, again, I'm in Wisconsin, have worked with a few of them, and some of that, I mean, like the places that do like the overdose mapping, for example, right? Like, what does that look like? There's a lot of different things out there, but I mean, I really appreciate that example, Brian, because it's a really like concrete example of what it looks like to you know, marry different ethoses and philosophies to make sure that everybody can get the services that they need. So I really appreciate that. Heather?
Yeah, I think we're about out of time, and I just want to thank everyone for attending, and really thank you, Rachel, for coming and talking with us. And as mentioned, we will share the slides and some other resources with everyone. Thank you. Have a great rest of your day.
Thanks, everyone.